Welcome to Decoding Multi-Omics to Tailored Therapy, the role of CGP in lung cancer, organized by Voice of Healthcare and supported by Zydus and Garant Health. Lung cancer treatment is no longer about one diagnosis, one drug, or one pathway. Today, every tumor carries its own molecular fingerprint, and by decoding genomics and epigenomic signals through CGP, we can move beyond guesswork towards truly tailored, precise, and life changing therapies for each patient. This discussion will explore how CGP is transforming lung cancer care from broader treatment approaches to truly precise patient centric decisions. To discuss this, we have with us Dr. Pramod Kumar Julka, Vice Chairman of Oncology at Max Institute of Cancer Care and Max Smart Super Speciality Hospital, Delhi. Welcome, sir.
Thank you.
So, sir, how would you explain genomic testing and why has it become such a critical component of cancer care today?
Nowadays, actually, genomic testing has become a critical and very essential issue because any patient, not only lung cancer, but all the cancers, as you said rightly, have genomic profiling, molecular profiling. I always used to say that your molecular horoscope, we want to make it. Like people talk of horoscopes. So we used to say molecular profiling, we used to call them molecular horoscopes. So basically, DNA is the basic molecule of life. We all know that DNA in cancer cells, we want to see what the DNA is doing, how the cancer is growing, and how the cancer is spreading, and how the cancer is becoming resistant to certain therapies. So it is very important for us to know the genomics. This is called genetic study, genomics. Now, next we come to multi-omics. Multi-omics means besides genetics, genomics, we are seeing the fusions also, the RNA studies, which we call them fusions. And besides fusions, we are doing epigenomics. Epigenomics is, as I always used to say, that there are certain letters in the book, and how to read a book is epigenomics. How do we read DNA fingerprinting? So basically, we have to see the multi-omics platform in any case of lung cancer. For example, we are talking of lung cancer. So without that, we cannot proceed to therapy, any therapy nowadays. So that is the crux.
Right, sir. And so it becomes, confusing for the patients. They sometimes can't understand the terms like comprehensive genomic profiling and hotspot testing. So, what do these mean?
Actually, I want to stress this point that in 1980s, we used to treat all lung cancer patients with chemotherapy, radiotherapy, and surgery if early. Nowadays, because of genomics coming in, comprehensive genomic profiling, we always say that this has to be done in all the cases. In certain cases where the patients feel that the treatment is being delayed, so we go in for hotspot testing. What is hotspot testing? It is a testing of certain genes which we already know. These are the genomic profiles found in lung cancer, which we already know, and we can do it early. Patients are, getting panicky because they say so much time is wasted on this. You get the treatment early. So we certainly we used to do hotspot testing, which is early testing and less expensive also, and but we find certain mutations which we also find more mutations in the comprehensive genomic profiling. Hotspot testing is a few mutations. CGP means comprehensive genomic profiling, where we have thousands of genes and we can take out certain actionable mutations from there.
And sir, why can hotspot testing fail to identify certain mutations, as you told, um, that CGP can able to pick up?
Yes, CGP can pick up much more mutations than hotspot testing. So that is why I always prefer doing a CGP and telling the patients that besides your hotspot panel, we are getting more mutations, and we'll be able to help you with oral therapies, targeted therapies, much more than chemotherapy. We can avoid chemotherapy in these cases, and we have done so. I would like to give you an example if it is,
Yes,
like
yes.
one of our patients, stage 4 lung cancer. He came to us, this was about 3, 4 years back, and then he had ROS1 mutation. So, ROS1 is a gene which is found in certain cases, very less number of cases, less than 4%. And we had given therapy for that. The patient was alive for 3 years, and then we got the CGP done again, where the ROS one disappeared. So this is another advantage of CGP. So where we can find the mutations, and then the mutations disappear, and then we started the patient on chemotherapy, and we took out the targeted drugs.
Very rightly said, sir, that mutations can disappear and they can appear as well, during the
Yes.
patient's journey of
Yeah.
cancer. So sometimes it becomes difficult to decide that when to do CGP. So according to you, sir, is CGP typically advised at the time of diagnosis, or is it more useful once the disease stops responding to the treatment?
No, it is very important at diagnosis as well as at progression of disease. So both places it is important. In diagnosis, it is important because of metastatic or advanced stage disease. For example, it is stage 4. So which is, that means disease has gone to brain or somewhere else, where we can find some other molecular mutations also, which can guide us to get therapy done.
Right. And sir, people are talking about epigenomics as well. So, how do you define epigenomics, and in what ways does it fundamentally differ from genomics or genetics?
Yes, epigenomics is addition to genomics. That means that epigenomics, I used to say that, we are reading a book. The complete book is the full CGP. And part of the highlighted words in the book are hotspot testing. And how to read a book is epigenomics. So epigenomics is basically, it is reversible, and it is changing. It can change from time to time. In epigenomics, we see methylation patterns. Methylation means adding a methyl group where we can silence certain genes. For example, I tell you about brain tumors. Brain tumors, we do MGMT, which is a gene to silence the tumor, and where our therapy acts has a resistant mechanism. So the therapy is resistant to certain therapies, for example, temozolomide in brain tumors. Even though we give it partially resistant therapy, so we can know by which epigenomic mechanism that which drug would be effective and which drug won't be effective.
And if we talk about, sir, liquid biopsy is also coming into being, and we have the CGP in liquid biopsy as well as in tissue biopsy.
Yes.
So, sir, what, according to you, is the most, relevant mode of doing CGP, whether it's a liquid biopsy or tissue biopsy in lung cancer patient?
Yes, lung cancer patient, it is very important to do a combo. Combo means solid plus liquid, ideally. So there we can pick up more genetic mutations, more fusions, more amplifications of the genes, and we can find out there is a mutation in lung cancer of ERB2 gene, which is found in breast cancer. So here also we have certain drugs which help us in overtaking, because we have patients with HER2 mutations in lung cancer, where we are treating them with antibody drug conjugate, which is trastuzumab deruxtecan, so which is giving very good responses. So here the advantage of combo means combined tissue testing plus the liquid biopsy. But in case where we are, progressing, we have done the tissue testing first time, then after 6 months or after 1 year, where we find the disease is not responding, we can go in for liquid biopsy and assess the resistant mechanism. If there is any, or if there is no resistant mechanism, we continue with the same therapy.
Right, sir. And sir, I also want to know that sometimes CGP picks up certain variants of unknown significance. So, how do you counsel the patient and how important are they?
Yes, there are certain times where we do, for example, we do hereditary gene panel with MLPA. MLPA means that we do more genetic testing in those cases where there are hereditary cancers, for example, breast cancer. So there, once we do the hereditary gene testing, we find that there are certain genes which are VUS. VUS means of variants of unknown significance. There we don't know whether it is significant or not. Then we wait and tell the various, genomics experts, and ask them whether they can be, what is the VAF? VAF means variant allele frequency. So we see the variant allele frequency, and in which case it could be VUS, or in which case it could be actionable mutation. So we can decide between that.
Right. And as far as the stage of lung cancer is concerned, what, according to you, should be the standard treatment of inculcating CGP as a routine testing? At what
Yes,
stage?
yes, we should do it every stage. That is
Okay.
what we teach. That it should not be done in only stage 4, or it should not be done only in like resistant mechanism. So not we should do it in all these stages, and this is very helpful, because earlier if we find EGFR mutation in lung cancer, we find ROS1, we find ALK mutation or fusions, we have the drugs to tackle each of the mutations. We have the drugs today.
Right. So I think anyone who is listening should, get it done at every stage of lung
Every
cancer. That is
stage.
very
Yes.
important.
Yes.
And sir, what according to you is the biggest barrier you feel that people are not getting this test done, CGP? Matlab, what is the barrier in its adoption?
Barrier is only financial toxicity. I used to say that this is only finances are the barriers, nothing else. And we have gone out of the way to get CGP done, even free of cost and even at low price from various sources. So, because this is very, we say, utterly important. So, very, very important to get CGP done, because without it, we cannot treat lung cancer at all. So why should we deny the patient of oral therapies, of simple therapies, which patient keep on taking at home? One of our patients, more than 5 years, is taking EGFR therapies. And one of the senior IAS officers, he is on osimertinib, which is anti-EGFR therapy, for 7 years. So you can imagine one tablet daily for 7 years. So lung cancer metastatic going on for 7 years, which we had not heard in 1970s or 80s when we started our practice in
Right.
oncology.
Right, sir. So, sir, what do you think is the future of cancer care? If we integrate epigenomics or CGP into the practice.
Yes, we always say that multi-omics, right from genomics. We say transcriptomics. Transcriptomics is RNA sequencing, and then we go on to epigenomics. Epigenomics is like, as I told you, it is adding to the genomics, and where we can find certain resistant mechanism. All this is leading to precision medicine, more precise and targeted medicine to the same person who is getting it done. So we have identified personalized medicine and precise medicine. That means if a patient A comes to us and we have done CGP for person A, then will be personalized treatment for person A, patient A, and it will be precise treatment. That means if a mutation in EGFR exon 18 or exon 21 is there, we are giving osimertinib or any other tablet. So that is personalized treatment and precise treatment for that patient. So that makes life much easier for the patient.
Right. So it is no longer a guesswork, it is individualized treatment for everyone. And here,
Yeah.
what comes the role of epigenomics and genomics, what we are talking about. And so, for people listening to us at home who don't have cancer, but they want to have some key takeaway from this discussion, what would that be?
They should think that there is a hope, and cancer could be curable or cancer could be controllable. So they should not fear from cancer. But here, one thing I would like to say that, our genes are modified according to how we live, how we what we eat, and whether we are doing smoking or taking alcohol, our genes will be modified, and the epigenomic factors will again be modified. So, for all the viewers, I would like to say that smoking and alcohol addiction, you should have balanced diet and exercise daily, and you should not avoid smoking because pollution, already we are smoking in a smokeless environment, so pollution is there, and alcohol should be avoided in any excess quantities.
Answer your views on one more question, that what is the role of these biomarker which we are discussing, like the liquid biopsy, epigenomics, in picking up early lung cancer detection today?
Yes, we can pick up early detection also by epigenomics, and that is a very important factor. Nowadays, simple blood test can tell you whether you are getting any cancer or not in early stages. So this is an mRNAs. They have been found to be the little source of energy for detecting early cancers, which people have got Nobel Prize last year for mRNA sequencing.
So I think it's a very futuristic test where we will be able to have the role in preventive oncology as well with the help of all these tests coming in. So now it's a time for rapid fire. So first question to you is that genomic testing, if you have to define in one line.
CGP, genomic. That is CGP.
Okay, they are synonyms. Okay, sir. So hotspot versus CGP.
CGP, I would go for CGP because
Okay.
hotspot is a few genes and CGP is the multiple genes, thousands of genes.
Right, sir. And why is CGP increasingly important in lung cancer care today?
Because CGP can detect cancer, various mutations, various fusions, various amplifications, all these in multiple genes, thousands of genes, and where we can pick up something and help the patient.
Right, sir. And what is the biggest risk of relying only on hotspot testing?
Hotspot testing, because in CGP we are taking actionable mutations. In hotspot, the life changing mutations, non hotspot mutations are missed. So that is a danger.
Right. And again, at what stage of disease is CGP most valuable?
At any stage,
At any
all the stages.
stage, all the
Generally,
stages.
we say at diagnosis and at progression,
Right.
and it should be
And sir,
done in all the.
yes, sir.
Yes.
Sir, Neil, a last message you want to give to our viewers, of how they can prevent, and something about early detection of lung cancer, where in these tests are definitely playing role.
Early detection of lung cancer, I would like to say avoid smoking in any form, then avoid alcohol, which adds to smoking was. And I would like to tell you here, because I was the in charge of Delhi Cancer Registry when I was dean at AIMS, New Delhi. So, what we used to see in National Cancer Registry program, if I would just give you a glimpse, we had 14 lakh new cancer cases every year in India, about. So out of 14 lakhs cases, 50%, 40 to 50% were attributed to smoking. Smoking, whether it is smokeless tobacco or smoking tobacco. So that is the scenario in India. And in Northeast, it is more than 50%. So I would like to tell you in the end that you should avoid smoking because pollution gives rise to already smoking. We are smoking in the environment. So please try to avoid smoking. Then your diet should be adequate in proteins, carbohydrate, and fats. We call it a balanced diet. Exercise daily, and you should have a good lifestyle because cancer is a lifestyle disease. We always tell all the patients lung cancer or breast cancer or any other cancer. Cancer is itself a lifestyle disease. So avoid all these things so that you can live your life in a better way.
On that note, I think people must have taken this good message that there are certain things, there are certain modifiable risk factors which are in your hands. Stop tobacco, stop smoking, and maintain a good, healthy lifestyle. So, with that note, thank you, sir, for joining us today and giving your insights.
Okay.